Hello, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for November 14, 2018. Thank you for joining our presentation this month. Our presenters today are Dr. Marie Westby and Cheryl Koehn. Dr. Westby is a physical therapy teaching supervisor in the Mary Pack Arthritis Program in Vancouver, BC, and holds a clinician sciences position in the Center for Hip Health and Mobility in Vancouver. She's a clinical associate professor in the Department of Physical Therapy, the University of British Columbia. She has also worked as a physical therapist in outpatient arthritis care for 30 years, treating clients with many forms of inflammatory and degenerative arthritis. Cheryl Koehn is an arthritis advocate, community leader, published author, and rheumatoid arthritis survivor for 30 years. She has dedicated her life to helping others living with arthritis, as well as other people living with other chronic diseases. She is the founder and president of the Arthritis Consumer Experts, a national patient-led organization that provides science-based information and education programs in both official languages to people with arthritis. Welcome, Marie and Cheryl.
Thank you.
Thank you so much, Haley.
Can you hear us okay?
Yes, we can hear you just fine.
Fantastic.
Well, thank you to the Osteoarthritis Action Alliance for giving us the opportunity to share our research today and to share our experiences in patient-oriented research. Just trying to advance our slides, but there we go. I'll have to use the mouse after all. So we have no disclosures. So I'm just going to start with a bit of an outline of osteoarthritis in Canada, just to set the stage and the number of hip and knee replacements and the process and models of care that are in place in Canada. Talk a little bit about the rehabilitation or rehab practice variation that is present locally here, just in Vancouver, as well as across Canada and really internationally. And basically use that as a starting point to provide the rationale for why we went on to develop quality indicators for hip and knee replacement rehabilitation. And I will be emphasizing that this really has been a joint effort, pun intended, between patients and clinicians and decision makers and researchers to develop tools and indicators that address the needs of all these multiple target audiences. I'll then talk a little bit more about the EQUIP-TJR, and I'll explain what that stands for, project in which we're developing a toolkit of resources targeting patients specifically, and then talk about the value of patients as partners and co-leads in this research project, and turn the presentation over to my colleague and co-lead on this project, Cheryl Koehn, to talk about her experiences as a patient, partner and researcher and co-researcher. So osteoarthritis in Canada is similar proportions to it is in the United States. Keep in mind that the Canadian population is about only 10 or 11% of what the US population is. But based on a large survey of over 200,000 electronic medical records back in 2012, looking at patients age 30 plus, about 14% of them had at least had osteoarthritis in at least one joint, about 16% female and 12% male. In a slightly earlier survey across Canada, Stats Canada survey looking at chronic disease, for those that reported having doctor-diagnosed arthritis, 37% of them had osteoarthritis. And of these, 12% had involvement of the hip, 29% of the knee, and actually 29% had involvement in both joints. So it's currently estimated that about 5 million people in Canada are living with osteoarthritis. And within a generation or the next 30 years, it's estimated that more than 10 million or 1 in 4 Canadians are expected to have osteoarthritis. So care in Canada varies like it does in the United States. And there's a number of guidelines that have been developed and indicators to provide clinicians guidance on the best practices and the evidence-based care. The NICE guidelines developed in the UK have been examined in a number of studies, and most recently in this one, eight general practices, over 1,700 patients. And they were looking at the adherence to 8 quality standards or indicators. And it ranged from 7% for patients in terms of being referred to physical therapy for exercise advice to as high as 63% for routine and standardized assessment from pain. So lots of opportunities for improvement there. Locally, back in 2011, Lee and colleagues did a survey, and I think someone might have unmuted there. Looked at 4 of the 14 Arthritis Foundation quality indicators for osteoarthritis, focusing on the non-pharmacological indicators, and found a range of 7 to 29% adherence with an average of 22%. Adherence was lowest for the assessment of non-ambulatory functions such as self-care, dressing, and grooming, and it was highest for assessment of ambulatory functions such as walking, walking speed, and gait. So again, lots of opportunities locally here in BC for improvement. So we know that pharmacological, non-pharmacological guidelines and tools are available. Last year in Canada, the Arthritis Alliance of Canada, in partnership with the College of Family Physicians of Canada, this is just a small screenshot of a tool at the bottom of the slide here, and with the Center for Effective Practice, developed a multi-page osteoarthritis decision tool to guide family practitioners in screening, history taking, assessments, and referral to appropriate care. This was developed with patients as part of the working group, but their role was fairly limited. And I've found with looking at a lot of the various guidelines and tools that there has been quite a limited involvement of true engagement of patients as partners in the development or as co-developers. And actually there's work underway from a working group developed from this larger group, engaging patients and asking them for their needs and priorities for the various aspects or sections of this tool, and to develop a patient-friendly tool or an OA patient information tool, and it is under development right now. There we go. Oops. So often for a patient who has failed to improve or maintain their function or quality of life following these indicator or evidence-based guidelines and get to the point where they're not able to function or to maintain work or the activities that they like to do, need to go on for consultation with an orthopedic surgeon and eventually a hip or knee replacement. So in Canada, that involves quite a lengthy wait. Once you are deemed appropriate to see an orthopedic surgeon, you could be waiting several months for that initial consultation. And then if the surgeon decides you are a good candidate for a total joint replacement, it could be then another several month wait to actually have the surgery. The benchmark in Canada for the point of determining that you need surgery to actually have the surgery is 6 months. And most provinces are doing not that great of a job of meeting that guideline or that benchmark right now. So unlike in the US where the waiting period is quite short, it's quite significant here in Canada. But the cost of the surgery and the inpatient stay and most of the rehabilitation is covered through our universal healthcare plan. So over 110,000 primary or first-time elective total joint replacements are done each year according to our Canadian Joint Replacement Registry, which is a national registry that records this data. And osteoarthritis, of course, is the main reason for people undergoing hip and knee replacement. After a short 2 to 4 day length of stay, and some hospitals are now looking at same-day discharge, majority of patients are discharged home. We don't have specialized nursing facilities in Canada, and we have a very limited number of inpatient rehabilitation beds. So different provinces and different hospitals have a different model of care, but locally, less than 5% of patients undergoing a hip or knee replacement in Vancouver are being admitted to any type of inpatient facility. They're being primarily discharged home. And then the rehab care is all over the map after that. This shows our province here of British Columbia, and then more specifically where the star is, where Vancouver is. And even locally, depending on which of the 5 hospitals that you had your surgery at in the Vancouver area, you could be discharged home with an immediate home care visit from a therapist. You could be discharged home and not asked to come back for 6 weeks after hip replacement, and then determine whether you need any therapy. Or you can be discharged and then admitted to an outpatient, fully paid for a group program that involves pool and land-based therapy twice a week for 8 weeks. So you can see it's very inconsistent and inequitable. And with all these variations in the approach and models of care for therapy, we're finding, and the literature supports, that 20 to 25% of patients are reporting persistent chronic pain, disability, and dissatisfaction 2, 5, and 8 to 10 years out after surgery, depending on how long they follow these patients. And the question that our group asked was, can some of this poor quality of outcomes or subpar outcomes be explained by the inconsistent, inadequate, or poor quality rehabilitation? So we thought, based on the volume of patients that are having these surgery and the projected increases in numbers of surgeries, there's variation in care and outcomes, and yet the available evidence that had yet to be synthesized in many areas of rehabilitation provided strong rationale for developing quality indicators in this patient population. So quality indicators are standardized, evidence-based measures of healthcare quality. They can relate to the process, structure, or outcomes of healthcare. Our quality indicators are focused on processes of care, so the delivery of actual interventions. Through a Delphi process with a Canada-wide panel, including orthopedic surgeons, physical therapists, other rehab providers, nursing, and patients, we developed 67 quality indicators, 31 for hip replacement, 36 for knee replacement. And these indicators span the continuum of care. So from the point that someone is placed on a surgical wait list through their acute care stay, and then up to 1 year post-operative, because earlier work with focus groups with patients suggested that they really felt they were rehabilitating or recovering from surgeries for as much as a year afterward. So after identifying the key rehab components, which we did together with our patient advisory panel, we synthesized the evidence with various aspects of care, presented the evidence to our Delphi panel, and they went through a rating and a consensus process. We then went on to pilot test the quality indicators in different clinical practice settings in Alberta to see, look at the feasibility of collecting data in different ways. These are a couple of the key articles that emerged from this work, which was part of my PhD and postdoctoral work. So we know that clinicians can use quality indicators to help them implement best practices, to track the quality of care they're giving, to report, to identify areas where there's care gaps, and maybe inform some of their plan due or PDSA cycles to improve care. But what I was really interested in is how patients and families can use these quality indicators. And we see that they can use them to make informed decisions about their healthcare options, and where they have options around selecting providers or programs for care, especially after surgery, they could use it to actually select a provider that maybe is has a higher adherence rate or is doing a better job at meeting these quality indicators. While they're under care, they can track the quality of care they receive and communicate their expectations and treatment goals with their providers, and have that conversation based on that they now have the knowledge as to what they should be looking for in good quality rehab care. So what we're doing is developing 2 online toolkits to house these quality indicators in formats or resources that are accessible and user-friendly. The toolkit for patients is called the EQUIP-TJR, and this name is an acronym, but it's really meant to relate to the fact we want to equip patients and their families with tools and resources to help them fully engage in their rehabilitation care. The toolkit for patients will include these quality indicators in plain language formats embedded in existing patient education booklets that most patients get as soon as they're put on the surgical wait list, a checklist that allows them to sort of monitor their care in real time in each phase of care, a questionnaire, which we'll be talking a little bit more about, that allows them to reflect back on the quality of care they received and share that information with their providers, or in our case, they'll be sharing it with us, the research team. A video, which we're calling a quality conversation, depicting a patient using some of the resources from the toolkit and having an effective conversation with their care provider around areas of concern around the care that they're receiving. Patients also wanted a passport, a small sort of pocket-sized resource that they could, again, monitor the indicators, track their appointments, write down their questions that they had for each visit, and a couple of other resources as well. And how did we know that this is what patients wanted? Well, what we did was a survey. So in the fall of last year, we conducted a survey for patients and for clinicians. The patient survey went out in the summer and into the fall, and we were able to get 137 responses from patients from across Canada and representing 8 provinces. We had a good mix of people that were having hip or knee replacement, as well as those that had had surgery or were still waiting for surgery. Those responses in terms of the different types of resources that they wanted are indicated in blue. And what we asked people to do was to rate how likely they would be to use each of these resources. The survey provided a picture of the resource and a brief description about it, and then we asked them to rate. So these numbers reflect those that rated that they were most likely or somewhat likely to use the resource if it was available to them. The orange bars depict the clinician survey, which we are calling QUICK-TJR. QUICK being because clinicians told me when we did some initial pilot testing that they needed tools that were quick and easy to implement into everyday practice. So you can see right off the bat that patients are more likely to use any of these tools and resources than clinicians are. Anywhere from about 10 to 38% more likely. And I think this is important because it shows that in order for these tools to be used and more likely to have the quality indicators met in routine practice, that we really need to target the patients and their families as well as the clinicians. And ultimately, patients are the key stakeholders in this process. They're the ones making that difficult decision to have a hip or knee replacement, to put in the time and the commitment to prepare for it, deal with the post-operative pain and the rehabilitation process that can be protracted sometimes, and the interruption it has to their family and to their work life. So we see patients as research partners and co-leads on this particular project. So what they have done in terms of engagement in this process is, even 10 years ago, as I mentioned, patients were part of our advisory panels that helped us to envision the scope of this project and identify what are the key elements of rehabilitation. They led the creation of plain language statements. So we had these 67 very technically worded quality indicators that they then created into plain language, user-friendly statements that are being used in all our subsequent tools, the checklists, the surveys, and the booklets. They helped to design and pilot test the focus groups that we conducted earlier last year, which informed the actual surveys. They co-created and pilot tested the online survey for us and then assisted us tremendously with survey recruitment. We then went on, based on the survey results, to develop a patient QI questionnaire that I mentioned. And we are now in the process of pilot testing that questionnaire. And our patient partners helped to recruit and pre-test the usability of this QI questionnaire to make sure that the online format worked and didn't have any technical glitches and the wording was clear. And now they're involved in helping us get the word out about this pilot test that we're conducting with the grant from the BC support unit here locally in Vancouver. So patients have been co-investigators and co-authors on our grants, on our papers, on our presentations, and it's been a fantastic opportunity, which I'll allude to some of sort of my take-home messages at the end. But I'd now like to turn this over to my colleague, Cheryl Koehn, to describe her experience and involvement in patient-oriented research in Canada.
Thank you very much, Marie. It gives me great pleasure to be with you here this afternoon via e-technology. And I'm really happy to share with you some of the learnings from my experience, kind of looking through the research glass from the patient side. As was mentioned at the start, I'm a person living with both osteoarthritis. In fact, that was my primary diagnosis about 35 years ago. And then 30 years ago, I was diagnosed with rheumatoid arthritis. And when I was diagnosed and looked out on the landscape, it was absolutely barren in terms of patient participation in research. Probably like many who are diagnosed with any type of chronic disease or illness, I didn't know really what research was. Fundamentally, I kind of understood, oh, it's things people do. But to understand how it works is a whole other kettle of fish. And back in the day, as this little cartoon or this little image depicts, there were some very early pioneers, and in Canada, and I would even argue in the world, the first research environment, I think, that recognized the importance that patients could play in the research process from start to end was the musculoskeletal research community. That's certainly its origin here in Canada. But back in the day, how we were involved, how we got involved, researchers who have all the power said, oh, that person sounds interesting, maybe we'll bring them to the meeting. So the engagement was very organic. There was I think, a true desire to have patients involved, but there was no plan or process, and it was really, hey, let's find a patient quick. It did take time to grow the ranks of informed patients who were both willing and able to participate in a meaningful way. And the early pioneers included Cochrane Canada, which is a group around the world that focuses on doing literature reviews and putting their results of these reviews into lay language. And that was one of the places that I started, as well as in the Canadian Arthritis Network. And it was in this federally funded research institute, the first of its kind for arthritis in Canada back in 1999, 2000. I was asked to join the management committee. So for the first time ever in Canada, we had a patient who was deciding not just what type of research was going to be done, but actually where the money would go, which is where you do develop equity. When you have a stake and a meaningful say in how budgets are developed and what type of research you're going to do, you know that you're there to stay. And then finally, the Canadian Institutes of Health Research formed shortly after, and we did receive one of our own institutes, the Institute of Musculoskeletal Health and Arthritis, or IMHA as we lovingly call it. Today, there's a number of frameworks that exist and are really, I think, being used to a great extent to meaningfully engage OA patients like myself. When we think about how we engage patients in the same way we think about how do we grow a network of researchers to think up a project and to execute a project, it takes money. And in Canada, Health Canada now has what they call a gated research fund called the Strategies for Patient-Oriented Research. Gated means they will protect it at all costs. It means that patient partners in research are here to stay in this country because of this gated funding. And more importantly, I think, than that, or as importantly as that, is the willingness of researchers. We can't, like researchers like Dr. Westby, you can't go back. You've been doing research since you were doing your Ph.D. with patients. So to consider doing it without patients, I'm going to argue would seem foreign to maybe even many of you on the listening in today. And we used to talk about research in pillars. And when we think about patient engagement, it's not about pillars, it's about the whole thing. It's about the pier, because you can't walk across water without the full pier. You can have pillars, but you need a pier. Which is my metaphor to introduce you to a really valuable tool that's been developed here in Canada called the Peer Framework. Super thoughtful, really energetic young researcher, Dr. Cleon Hamilton, and his equal patient partner researchers developed this framework that really helps get at the sort of the core of what kind of procedural requirements in patient engagement are necessary to do it well, to do it right. Engagement has been sort of catch as catch can. Oh yeah, we forgot to put a patient here, we better run out and get one. this is a process and a framework that helps both researchers, funders, patients, and communities overall develop, understand, and define what procedural requirements need to be in place. And I'm not going to read all of these out to you in the interest of time. You certainly can read them there on the screen, and the lovely cartoon that depicts these important areas of involvement. Goal setting, clearly at the start, is a very important exercise. How we determine what our abilities are and how we share perspectives, where we want to be involved and perhaps where we don't want to be involved. Maybe there are some stages of research where we don't have perhaps the technical expertise or don't have the time or the money, frankly, to be involved in terms of recovering our lost opportunity. So all of these things down this list are fundamental to a framework that's going to ensure that you have meaningful engagement of patients throughout. So we went from that covered wagon going across the tundra with some sort of pioneers who were freezing cold and probably hungry to a couple of different frameworks that I'm aware of and have been a part of implementing or using in research today. And the key thing about I think lessons learned along the way, I think Maria and I are going to close here. For me, it's these four simple thoughts. Even though you think you know how to be meaningfully involved as a patient research partner, or on the researcher side, if you think you know how to do it, we encourage you to find and use a validated framework co-designed by patients and researchers, because that is your ethical guide from the day the work starts to throughout the project's life cycle. I've mentioned one framework. There are several others. There are some resources we'll provide at the end. Patient engagement still has not addressed the underrepresentation of underserved patient populations in patient-oriented research. And I think this is our biggest gap and the thing we have to work on the most right now. We just don't have underserved populations at the table expressing their voice, expressing their perspectives, because it's challenging for them to get to the table. It's challenging to identify people from those communities who want to participate. And lastly, I would say we'll sustain transparent, validated patient engagement efforts in the research process, make a difference in the uptake of treatments or self-care guidelines, such as the ones that Dr. Westby outlined for us this afternoon. But most importantly, are they going to improve patient outcomes?
I'm going to leave you with the final word there, Cheryl, just to see if there's any questions. Yeah. But there are a lot of lessons learned on my part as a researcher, as you noticed as well. And these are available to reflect on when you look at the slides or download it later. I just want to acknowledge Cheryl as the co-lead in this project, our other patient partners, Alison Hoons, who has been our knowledge broker and helping us create a larger team and brokering and leveraging services from other organizations. We have a patient-oriented research trainee, and of course all our patient or research participants, our funders, the BC Support Unit and Vancouver Coastal Health Research Institute. We'll leave you with a couple of resources that we'd encourage you to look at if you're more interested in learning about patient-oriented research. And we'll leave you with a beautiful picture of Vancouver and encourage you to follow us on Twitter if you'd like to learn more about our project. And now we'll be happy to take any questions in the last 45 seconds.
Thank you so much, Marie and Cheryl, for your presentation today.